Hello and welcome. I'm Dr. Phil Hammond. Welcome to this webinar talking about respiratory allergy in the time of COVID-19. I'm an associate specialist in pediatric chronic fatigue, and I work at the Royal United Hospital in Bath in the United Kingdom. And I'm delighted to be joined by three experts in respiratory allergy, Professor Graham Roberts, Professor Margita Varum, and Professor Leif Bjerma. Graham, kick us off. Tell us a little bit about yourself, your interests, and how the pandemic has affected your practice in the last couple of months.
So, good morning, everyone. I'm speaking to you from Winchester in the south of England in the UK. I'm a paediatrician. I split my time between looking after kids with respiratory problems on the wards and in outpatients with allergy, asthma, and other issues. So how has it affected me? So my outpatient work is now all virtual. So we do it all on a web conference system. I've seen one patient in outpatient physically, face to face. Inpatient work, well, it's just dried up. Suddenly all my respiratory patients who I normally look after in the hospital have disappeared. I had one patient to look after last week. Very strange few months.
And just briefly, do you worry about that we're creating an iceberg of unmet need by not seeing people as we routinely would do in our outpatient clinics?
Absolutely. I mean, there's only so much I can do using a virtual system. I'm booking all of these people back into clinic in the autumn when hopefully I can do the skin prick testing, start the immunotherapy, etc. So yes, there is a huge amount of work just waiting to be done.
Professor Margita Varum, speaking to us from Berlin. Germany, widely praised as one of the countries in Europe is tackling this pandemic the best. How has it affected your clinical practice and what are your particular areas of interest?
Yes, hello everybody. I am basically seeing outpatients in the allergy and immunology clinic, and we were affected pretty much as we had to reduce our patient contacts almost to less than 20%. We were continue to see patients with specific immunotherapy on venom, and all the other patients we were either contacting via telephone or we also installed video conferences. So we were affected quite a lot also at the beginning to do a lot of management and the way to see patients switched from reality to virtuality, so to speak.
And in terms of the risk issues involved there, do you think that the patients you're seeing virtually are at increased risk, or do you think actually now you've managed the risk and it's pretty similar to seeing someone face to face?
Well, I think it depends a little bit. If we have patients we already know and we keep on seeing once or twice a year, this is more easy to handle, I would say. If we are in touch with new patients, this normally requires an allergy workup, for example, and of course, via a video visit, many things cannot be realized. So I would say for those who are appointed for the first times, we clearly face limitations.
So, Professor Leif Bjerma, you're based in Sweden, but currently in Norway. Is that right?
Yeah, that's true. I'm fortunate. I have half of my family in Norway, so now I'm not allowed to return. So I also been very virtual. So I have a Zoom or telephone consultations with my patients, and I think it works out very nice. And now it's during the pollen season, but fortunately, most of the patients, they are already on slit therapy, for example. They do manage it themselves. Or for those with severe asthma, the majority are doing home administration. So I think the follow-up on the web and telephone works quite nice, and it's always the possibility is always there that there is one nurse at least at the department that can see the patients, on site if necessary.
Do you think this will change your way of practice? Do you think having done it this way, you'll actually not want to go back? You'll be doing more teleconsultations and online consulting?
Yeah, I'm confident about that. We will have more and more virtual consultations. We can send out questionnaires. We can ask the patient to take blood samples and test in advance, and then we can have a very effective web consultation with them. So I'm sure that this will make changes in the future.
So tell us a little bit, Leif, about risk factors and respiratory allergies. So a lot of people would assume that if you had respiratory allergies and asthma, that might make you more vulnerable to COVID-19. Does the evidence say that that is true?
No, actually, it's the other way around. I have been contacted by a lot of patients who are very worried about that they are in risk. But as the data tells us now, it's actually, it can as well be that allergy, or especially allergic asthma, is sort of a little bit protected. We know that, for example, in those with severe COVID, there are very, very few with allergy or asthma recorded. And we know that eosinophils are a positive prognostic sign. And it has recently been shown also that patients with allergy, they have downregulate the number of ACE2 receptors, and that's the sort of the entrance for the COVID virus. So I don't think it's a risk factor, no.
Are you finding that too, Margita, amongst your patients, that the ones who have severe asthma and allergy are actually less at risk from serious COVID-19 disease?
Well, I cannot really comment on that because I have not seen any patient from our department who also had a COVID-19 infection. But in principle, as mentioned by Leif, we are at least not expecting that our allergy patients are at higher risk. However, we did these days enforced our patient to continue their medication, since an ongoing allergic inflammatory response in the tissues, at least we know this, in case of an additional virus infection can lead to an exacerbation of the allergic inflammation. So we tried really to communicate that it's very important as always, but in these days in particular, really to continue the medication for allergy.
And Graham, from your perspective, children don't seem to be much affected seriously by COVID at all. Do we have any idea why that is?
Yeah, can I just pick up on the asthma question a bit? And
yes,
then
absolutely.
I'll come to the children if that's okay. So we know that respiratory viruses are one of the key drivers for asthma, as well as allergies. But in terms of respiratory viruses, what's happened is the world has gone into lockdown. And that's a really effective way of stopping transmission of respiratory viruses. This is exactly, of course, what we need to do with COVID-19, but it's also stopped transmission of all the other viruses. So one of the key drivers for asthma attacks may have been suppressed in the last couple of months when we've been on lockdown. And that may explain why actually we haven't seen really, well, I've had one of my severe asthmatic patients come into Southampton. That's it, which is extraordinary. Wow. So it may be that actually this is a bit artificial and we need to wait to see what happens when lockdown stops. The other thing, of course, is all our patients are being adherent to their medication now, which of course is going to compound the situation. So there are lots of complicated things going on here, but actually the good news for our asthma patients is they're not experiencing problems, but we've got to watch and see what happens once lockdown is relaxed.
Do you think the improvement in air quality and less pollution, is that also an important factor in improving asthma?
Yeah, absolutely. I mean, I live in a small town, but it's heavily polluted by cars, and that's just disappeared overnight. So that is also another big component.
Sorry, Margita, you wanted
to say something?
Yeah, Margita.
Yes, I just wanted to bring in a possible issue which may also be relevant do we think that maybe as our patients also went out less, and if they are pollen sensitized, so they were maybe less exposed also these days?
Yes.
Do you think that's true, Life? Do you think that because they're going out less, they're less exposed to things that would have triggered their allergies?
Could as well be, and I also agree with Graham here that I mean, we know that all respiratory virus events has decreased a lot. One thing that I really are missing is lacking is a phenotyping of patients, because now we are talking about allergic asthma and allergy. The other patients on the other spectrum, those who are like eosinophilic non-allergic or severe non-allergic, whether or not they are at risk, we don't know. So it's the same with the COPD patient. We know that those COPD patients they are at higher risk, but we don't know how severe they are before they enter. So
okay, in terms of the very basics of making an accurate diagnosis, is it easy to distinguish between the symptoms of respiratory allergy and the symptoms of COVID-19 when somebody's presenting to you? Is it an easy diagnosis to make? Life, I'll ask you that one first. Again, stay with you.
I mean, there are some common patterns like nasal congestion, etc. But there are also typical symptoms that you can't differentiate from ordinary allergy. For example, the sneezing, itching. There are some funny phenomena with COVID. For example, the patient with very mild early symptoms, they report loss of smell. So that's a very specific pathophysiologic phenomenon. But and of course you don't have fever if you have allergies. So most of the patients they recognize when they get allergic symptoms. The problem is those who have not defined their allergy beforehand. There can be a mix.
Are you finding that too, Margita, that it's an easy differential diagnosis to make between respiratory allergy and COVID symptoms?
Yeah, I would agree with Life that most allergic patients, they had or report similar symptoms the season before or the year before. And the itching, in addition, the red eyes are also an important symptoms we see probably exclusively in allergy, and also the sneezing attacks, so like 5-10 times sneezing, and of course the fever I would also say is very important in the differential. The smell loss, I would say, I don't know, is probably a symptom supposed to come up later, as far as I heard. So at the beginning, this although it's unique probably for virus infection, but not in early symptoms, I guess. So.
And Graham, tell us about the pediatrics, presumably very different presentations. Has there ever been smell loss reported in a child yet?
Not that I know of. I'm going to say actually it's next to impossible to know with children. Right. The presentation is so variable. A lot of them seem to be asymptomatic, and knowing whether the patient in front of you or down the telephone line or on the virtual consult has COVID or the start of allergic rhinitis, I think it's very difficult. I think what you need to do is treat. So treat with an antihistamine, potentially, and see what happens. If there's a good response to treatment, well, it's probably going to be allergic rhinitis. If they carry on, they develop fevers, well, it's probably going to be COVID-19. So I think you've got to have your differential diagnoses with these children and just see what happens over time.
Have you been doing that too, Leif? Are there some patients you're not sure what it is, and so you do a trial of treatment to see if it works?
Yeah, that's the common practice. You treat and see. But one thing with the smell here, it's not only loss of smell, it's actually dysfunctional smell. You smell differently. And that's something very specific, I believe.
Do we think the virus is actually harming or affecting the olfactory nerve? Is it that specific in how the virus
Yeah, I think works? It's something like that, yeah.
Well, I learned from the ENT doctors at the Charité that loss of smell is something which is known to occur after virus infection. So I didn't know this actually. So I was, yeah, that
I'm
was
just looking
new
at
for
our
me.
attendees. We now have 505 attendees listening to us. So thank you very much for joining us. If you're only just joining us, you're listening to a discussion of the management of respiratory allergy in the time of COVID-19, and we've talked about how to make that differential diagnosis, how a lot of consulting now is being done online, and there are certain risks attached to that, but it may in fact be the future. We may find there are certain elements of how we're now having to practice that we keep for the future. In terms of therapies and managing therapies, and you were saying, Leif, a lot of patients now self-administer, and that's quite a big ask, isn't it? It's good if people can take control and manage their own disease and do it well, but there are certain risks involved in self-management as well, aren't they? Tell us a little bit about how you risk assess whether somebody can self-manage.
When I talk about that, that was the self-administration of biologics. And fortunately, we have now auto-injectors and self-injector syringes that the patient are using, and it's very safe, actually. I mean, they start up with the first 2-3 injections in the clinic, and they are being taught how to use it, and then they can manage.
So there's no risk of, I'm not an expert here, so I'm just asking a basic question. There's no risk of an anaphylactic reaction from self-administration?
Very few, no, it does not. So we are doing this for both omalizumab, we are doing it for the anti-IL-5 and also for the anti-IL-4/13. So it's really good. It works nice.
And as far as you're aware, is that happening right across Europe, or there are some countries adopting a slightly more cautious approach?
There might be different practices, but I think it's quite widely spread now over Europe, yeah.
So from what you're saying, there isn't much need to cut back on service provision at all in the management of respiratory allergy. We can do it just as well despite the challenge of COVID. Is that your experience?
Yeah, that's true. That's true. And especially if you follow up. So what we do now is the patient, they meet up when they start the treatment. They meet up, they train how to inject, and then they can do a number of injections themselves at home, and then they come back for a follow-up visit. And there, of course, during the COVID, we can sort of postpone that and make this period before evaluation, between the evaluation, to be a little bit longer.
Okay. So at the moment, you're not able to initiate treatment with new patients. You're having to put that on hold, are you, in terms of injection?
Yeah, that's true. We have actually done it. There is one nurse in the clinic still that can meet patients. If we have good precautions, we can also initiate treatment. So I actually done it. Yeah.
So you are initiating. How about you, Margarita? Are you still able to initiate injection therapies for new patients, or is that too difficult at the moment in Berlin?
Well, we are mostly continuing treatments, and this also works very well. It's not necessary to see the patients, and we can organize that they get their prescriptions. In terms of initiation, in particular immunotherapy, normally for pollen allergy, we do not start these days. We start in September, October. Okay. So that's not so much an issue. And for venom allergy, we usually do the initiation in-house in 2 days, and we had to stop this for the last 6 weeks, but these patients are on the priority list as the insects are coming soon. And if we have patients who had life-threatening reactions, they are on top of the list. So we start to initiate venom treatment, specific or venom immunotherapy. I expect within the next 2 weeks we will start this again.
Okay. And I know you're working in pediatrics, Graham. Are you any understanding of what's happening in adult practice in the UK as well as in pediatrics?
Well, I think we as pediatricians are actually following very much what our adult colleagues are doing. So we've swapped severe asthma patients to having their biological treatments at home. and that's worked very well with the teenagers. Most of my teenage severe asthmatics have coexisting food allergies, so they all have adrenaline auto-injectors, which mitigates the anaphylaxis question, but it's very, very rare with the biologicals. I guess as with Margita, our biggest issue is injection immunotherapy, particularly with those venom, and this would be the time of year when we would be pushing the venom patients through. All our pollen ones are already on therapy. I suspect this might be one of those things that pushes us more to use more of the sublingual immunotherapy for the pollen patients than some of us have used before, because that is so much easier to start, and patients should just carry it on their own at home. But I mean, we're lucky that it's occurred now. If this had been December, January, February, when we were starting off all the pollen patients on immunotherapy, it would have been a real challenge.
And tell me, as a non-expert, tell me about the sublingual presentation. Is that as effective as injections if you're giving it sublingual?
For most patients, yes, it seems to be as effective as the injection. There's very little head-to-head trial data, so it's difficult to be absolute, but a lot of patients have a very good experience of in terms of minimizing their pollen and house dust mite driven symptoms with the sublingular drops. Much simpler, you can give it at home, doesn't involve injections. So there's been a huge move towards that in the allergy world over the last 5 to 10 years.
So from what you're all saying, you're actually managing your practice pretty well. Well, apart from Graham's other outpatient work going down so dramatically, it sounds as if you're providing a high quality respiratory allergy service to your patients in a slightly different way. Would you say that was true life? I know you're very interested in looking at risks. Are there still any specific risks you think we haven't mentioned that patients and staff need to be aware of?
Well, I think, as I said, if we have now a pause like for 2 months or something, we can manage without any problems. But if the period gets more extended, then we have a problem, because we cannot really, see new patients and initiate the new treatment, etc. So there will be a lag. And that's of course harmful, but hopefully, we go back into ordinary business in the beginning of the autumn, and then I think it's no big deal.
Is there any difficulty in getting access to any of the medications at the moment?
No.
You're not finding any? And
No.
There are some issues around some of the asthma medications. So Clenil is something that we use a lot of in the UK. But there are other options that people are using, so there are workabouts. So they're minor issues.
Okay. And the same for you, Margita, in Germany. Do you have access to all the medications you need in your?
Yes, at least in the allergy sector, there have been some shortages in antibiotics and then other drugs, but not as it concerns allergy treatment. I would like to follow up what Leif said and also what you said. And of course, we are all happy that we were able to manage our patients the last weeks, and I would say also by using telephone video conferences, I would say in a pretty good manner. But what Leif said and also what I said, and it's probably also true for Graham, that we did had a reduction of seeing new patients, and we have, at least in my department, waiting times for new patients up to 6 months. So we are currently facing a little bit the problem, we have to squeeze in now these patients, or they have longer waiting times, and if it's too late in autumn, we have difficulties to initiate, for example, immunotherapy. So to put it positive, as we mentioned, we now introduced video outpatient clinic, and this may also enable us to increase the number of patients we are seeing, and thereby being able also to catch up those patients we were not able to see the last weeks, new patients.
It's interesting, isn't it? I'm seeing in my pediatric chronic fatigue service, I'm seeing all my patients via Skype at the moment. Very unusually for the National Health Service, they give us up to 90 minutes for each consultation, because fatigue is often very complex and there are often quite complex psychosocial issues. Teenagers often have high levels of anxiety and depression, sometimes self-harm, sometimes eating disorder, and some of it can be done really well on Skype consultations, and some of them you just can't quite risk manage enough. And you're never quite sure, with a family, you're never quite sure who's in the room, who's off camera, what dynamic is going in. In a clinic, you can separate one person from another. And so it's interesting. There are lots of risks that we're managing. And I think we've adapted very well and are learning very well, but there was still some risks at the background that flash up that you know you can't completely manage with an online service. I just finally, sort of to round it up, because we come from 3 different countries, well, Graham and I are in the same country, just thinking about how things have been managed. I know you're in Norway, Leif, but you're from Sweden. And Sweden has adopted a very different approach to Germany, and the UK is probably somewhere in between Germany and Sweden and falling through the cracks. Yeah. Tell us a little bit about you, because you're really interested in risk, how you think your government has managed it, and things perhaps they could have done better in terms of managing this pandemic.
Well, in Norway, they had the philosophy, put out the fire and do it quickly. And there the politicians are the one that make all the talks, the speeches to the people, and they are sort of advised by specialists. In Sweden, it's the other way around, and they say, let it burn, but let it burn not too fast so we can manage. And there the experts are ruling, and the politicians are standing in the background. So it's really a schizophrenic situation. I think which model is best, we will see for the future. There are very few that have been infected in Norway, and the number are of course bigger in Sweden. But the problem in Sweden is that they don't test enough, so they don't have the instrument to really monitor what's happening, and that's my big worry.
How about Germany, Margita? We look on very jealously at the way that Germany has managed the pandemic from the United Kingdom. Why do you think you managed it so much better than some other European countries? What was Germany's secret?
Well, I can say that in Germany, health protection is something which is on top and is also seen as a political task. So it is if we have a pandemic situation, it becomes a political issue, and there are advisors for the politicians, scientific advisors, and they also follow their recommendations with the overall goal of health protection to everybody in the population. You know, the price for this is very high, of course. Yeah. But the people so far, there was a very high agreement of the population to follow the recommendations of the government, and it was also possible. Germany is structured in a federalistic system. So this means the different states can decide differently, but they tried really to have something like an umbrella. And for the last 6 weeks, this worked, and it worked so well that the COVID wards, which were built up in a very short period of time, did not fill up at all. So we were even able to treat patients from Italy and France and Germany.
Do you think you'll manage to avoid a big second wave? Because that seems to be the fear. Do you think
Yes,
you'll be on top of that as well?
This is the key question currently, and within these days, the restrictions are going away, or we are going back to normal life, and then we will see what's happening. We do also have a lot of elderly people living in nursing homes, and we had already examples where this can spread enough very, very quickly. But I think we learned also from Italy that you have areas where you have super spreading of the virus, and these areas are hospitals, are kindergartens and schools, and we have to see. And we also learned, I think, the testing is now very much increased. Not only patients are tested or individuals are tested who have symptoms, but currently there's a lot of effort to get a better idea about the real situation, so to speak.
And what about you, Graham, watching from the United Kingdom?
Yeah,
possibly
okay.
jealously. How do you think we've managed it? And do you have any specific concerns as a paediatrician about the way we're managing COVID?
So I think the government forgot that we're such an international country. We have millions of people come into the country every month. And of course, we weren't testing, so we didn't realize just how many cases there were in the UK. Now, on a positive, I think we've done a really good job of ramping up our National Health Service. And we've had, well, you've seen the deaths from the UK, it's over 30,000. I mean, huge burden, but actually we coped because the doctors and nurses, the rest of the health service has really ramped up what they've done. So there's good and there's bad things about how the UK has actually approached it. Hopefully it means that actually a fair proportion of our population have had it and have some immunity. So the second peak of infection that's surely going to come in the autumn is not going to be as bad. But I think we've still got things to learn. I think one of the learning lessons is that we all assumed this was going to be like influenza. We all assumed that the broad masses of the population were going to be fairly equally affected, particularly children. And we're learning that actually that isn't the case. And we've really clamped down across the whole of society, where actually we could have probably got away with actually allowing at least some people to be out, and as I say, particularly these children. And if I can, just say a few things about the pediatrics. There's now some data, not all of it's published, it's all out in the public domain, so it's available for people to criticize. Most of the studies suggest that children are less affected by this. They're less likely to get infected compared to adults in the same country. We know from our pediatric wards that children very rarely get severe disease. There have been a few children in the UK who've ended up in intensive care. There have been a few deaths, but they're very, very small numbers compared to adults. And we also know from contact tracing studies that children very rarely pass it on to other people. So there is something special about children, and it may be, Leif, you mentioned ACE2 receptors. It may be that children just don't have many of those receptors, which is the door for this virus to get into the cells. They may not have very many of them in the lower airway, so they're relatively protected. There could be other reasons. We know that increasing age is the biggest risk factor, and then comorbidities. So, and we know that 20-year-olds have got a very low morbidity mortality. So it may be a graduation from 0 to 100. Children are just on the right end. And I feel, and a lot of my colleagues feel as paediatricians, we are overburdening the kids. We should let them out back to school and let them back to my allergy clinic, please.
Yes, I think that's a really interesting debate, isn't it? And it's very hard. We're not very good at releasing data, but you need to release both sides of the model. So the model that says lockdown's a good idea, and the model that says here are the side effects of lockdown, and you need to see both sides of the data. And We're not so keen on that. So finally, people listening to this who are trying to manage their respiratory allergy clinics and maybe a little bit behind you lot, just finally end up with your top tips for somebody trying to keep their respiratory allergy service going. What would you say to them? It's fairly optimistic, I guess, Leif, from what you were saying. What would you tell people watching this?
Yeah, to keep the contact, and you can do it virtually, actually, very much. So that's the most important. Be available. And the good thing with this is that you can be more flexible also in timing. I mean, you can have consultations spread all over the time, even the evening. So I think that's you will have another relation with your patient, another way to schedule your consultations. So I think we have learned a lot of positive things also from this.
I think that's a very interesting point you say about keep the contact and keep the connection, because we know connection as a principle is really important to health. We know social isolation is very bad for you. So although we talk about social distancing, what we mean is physical distancing. It's actually important to keep connecting with people. So that was a really interesting point. How about you, Margita, to people running a service, what top tips would you give them?
Well, it's a little difficult as the most important point was already mentioned. So besides that, I would say, besides keeping the contact, is also to make sure that the patients receive their medication they need, and also that they know that they can reach us. So I had many patients who contacted me via mail were asking, and they were so happy if they received relatively quickly an answer. So I think that they know we are here, even if we do not see them physically. We can phone them, or the other ways we already discussed, and that they know also there is no shortage in the medication they need. I think this is also very important.
Yeah, they need that reassurance. And any tips for pediatric services, Graham?
Well, I think I agree with both Margita and Leif. I think really important to actually see all the patients virtually initially, and a lot of the challenges, the patient challenges, you can sort out and start some treatments. But then there are patients that we can see, and I think as long as you risk assess, use personal protective equipment as required, I am seeing patients, and there are things that you can do to firm up diagnoses and start the appropriate treatment. And then it's prioritizing those patients to come into face-to-face clinics once we can start. Which ones really need the skin prick testing to firm up the diagnosis and tell them what foods to avoid, which need those extra respiratory tests that we utilize for fine-tuning the asthma treatment.
Do you worry, final question, do you worry about your own personal health? When this started, I volunteered at my hospital for frontline work, and my consultant said, you're male, you're 58, you've got high blood pressure, you'll just make the statistics worse. So I was sent home to do Skype clinics, and I live in the southwest of England, which has the lowest outbreak in the UK. So I guess we've had less anyway. Do you worry about your own risk, Graham, given we've had some shortages of PPE in the NHS?
Yeah. So I probably had it. I don't know, because of course we're not testing very much in the UK. And I probably got it from the last face-to-face clinic I did. There were nobody in that clinic, to me, who seemed to have COVID-19. I could have been the staff or whoever. So I think the lesson from that is actually we got to be very safe interacting with patients face-to-face. You've got to assume that actually the patient you're seeing could have COVID-19 and take those PPE precautions. And of course, I wasn't doing that because that wasn't part of how we do things. So once lockdown finishes in the UK, my expectation is I'm going to be wearing a face mask, possibly goggles, an apron in clinic, regardless of who I'm seeing. Because yes, we do have to protect ourselves.
Would that be the same for you, Margita? Will you be wearing PPE when you see patients face to face?
Yes, yes, we have installed this. We have face masks. We have increased hygiene restrictions, and I guess that's a certain risk you always have. And privately, I try, to be physical active and eat healthy things, and so. And I think a positive attitude is also helpful, and a good sleep is also important.
That's important. And you, Leif, are you all masked up when you're seeing patients?
Well, yeah, you said I'm also at risk, but I think that we also, by knowing more about the virus, I mean, the virus is vulnerable. It's easy to clean away, and it's easy to, if you know how to protect, then you can compensate the risk by the correct behavior.
It's also interesting that the highest death, your two ways of dying from this is A, to catch it, and B, not to be terribly healthy. We know it's a big wake-up call for public health, and that we have high levels of obesity, of type 2 diabetes, of all sorts of chronic diseases in the UK, and those people seem to be particularly vulnerable. So maybe the other big lesson that'll come out of this will be a big public health drive to get people as fit as possible in case a respiratory virus comes their way in the future. Do you think that's likely to happen? Yeah. Okay, I'm going to wind it up there. I think we've had a very instructive 40 minutes. It's been an absolute delight sharing those 40 minutes with Professor Graham Roberts, Professor Margita Boehm, and Professor Leif Bjerme. We may well follow this up with another webcam at some stage where we also take your questions. But thank you very much for taking the time to join us. And I hope you found this useful. Goodbye, everyone.